Welcome, everyone. Today, we're having the second academic seminar series from the MANNA Institute here in Philadelphia. We will be talking about nutrition and kidney disease with Professor Maya Clark-Kuteya. And we will be starting in just a second. Before we do, I'm going to give you a little bit of introduction to the MANNA Institute and our seminar series today. I'm Julian Henstenberg. I'm Director of Research and Evaluation here at MANNA and head of the MANNA Institute. I'll tell you a little bit about the MANNA Institute today. We will then be followed by our seminar presentation. We would also like to answer your questions. So please put your questions, use the chat to submit your questions. You can submit them directly to me or to the whole group if you choose. I will be recording the questions, and we will ask Dr. Clark-Kuteya at the end of her presentation the questions that we have. Now progressing again. Excuse me a second, we're just fixing a technical difficulty. Okay, we're back. So what is the MANNA Institute? The MANNA Institute is a division of MANNA where we explore the impact of nutrition on health for people with serious illness. Our role in this division is to conduct research and evaluation efforts. We also educate healthcare practitioners and consumers, and we share findings and best practices for improved service delivery and ultimately healthcare transformation, where we can use the power of medically tailored meals as part of medical treatment. And certainly that's what we'll be talking about today. During the month of March, MANNA offers the Nourish series, which is our celebration of National Nutrition Month. This seminar is part of that series, and it's sponsored by our Apple a Day sponsor, the Pennsylvania Health and Wellness. So today, for our seminar speaker, we welcome Maya Clark-Kuteya. She's an assistant professor at New York University, Bristol Myers College of Nursing. Her research focuses on the increased risk in terms of morbidity and mortality that result from end-stage renal disease and hemodialysis renal replacement therapy. Motivated by her diverse clinical experience as a nurse practitioner in the fields of general surgery, otorhinolaryngology, and urology in adults, and her personal experiences with chronic conditions in her family, her overarching goal is to improve the lives of dialysis patients. Welcome, and I'm going to turn the screen over to Dr. Clark-Cutaia at this time.
Let's see if we can make this work. Can everyone see my screen? Is the screen share working?
Yes, it is.
Okay, perfect. As Julianne said, my name is Maya Clark-Cutaia. I'm assistant professor at NYU Roy Myers College of Nursing. I am extremely ecstatic to be here with you today and to share some of the work that I've been doing in regards to dietary sodium restriction and the impact it has on outcomes in patients with end-stage kidney disease. So we're going to start today with our roadmap, just to give you an idea of what we're going to do. So we're going to begin with a little bit of a chronic kidney disease overview. I'll discuss with you a little bit in regards to how I'm trying to help with the vulnerability that dialysis patients experience in terms of inequities, and then next steps regarding the research and work that I plan to do in this patient population. So as a health equities researcher, I try to function in all aspects of my life with a health equity lens, whether that's managing patients or conducting research. And every time I see this image, that is what this reminds me of. This is a print from an artist in New Orleans named Terrence Osborne, and it is entitled Katrina Evacuation Plan. He has a series of evacuation plans related to the loss of life and the natural disaster during Katrina. And I think that this is what I feel like my patients, my chronic kidney disease patients, come to me with every single day. They are that VW bus carrying all this load on their backs. And one of, I feel like my goal in life is to somehow alleviate this burden that they seem to carry on a regular basis. So to give you some background, chronic kidney disease is a major chronic illness. It's growing in epidemic proportions. It is the 12th most common cause of death, accounting for about 1 million deaths each year worldwide. And the guess is that we're somewhere around 14% in total numbers of folks who experience CKD in their lifetimes. There are over 2.5 million people with end-stage renal disease across the globe that depend on this life-sustaining treatment, either dialysis or some form of peritoneal dialysis. The prevalence of Americans diagnosed with kidney disease has also continued to rise. It's the 9th leading cause of death in the US, with over 30 million Americans, or at least 15% of Americans, with CKD. From 2016 to 2017, the number of Medicare patients with diagnosed CKD went from 13.8 to 14.5%, and it's expected that it's going to be somewhere around 17% by 2030. The population burden leads to a lot of economic consequences. The total Medicare spending for all stages of CKD is more than $120 billion, and there is less than 1% of the Medicare population that is using this $120 billion. What that breaks down to is about $84 billion to patients who have the earlier stages of chronic kidney disease, and then the remaining $35.9 billion is those patients in the end-stage group, which is the patient population that I work with, and that's again about 7%, give or take, of the Medicare budget being spent on 1% of the Medicare population. So end-stage renal disease, here we go. The incidence of end-stage renal disease in the United States, again, this is the final stage and the most severe stage of chronic kidney disease, ranks among the highest in the world. There are about 726,000 Americans on dialysis or living with a kidney transplant, over 500,000 of which are patients who receive dialysis treatments daily. And most of those are thrice weekly, in center, 3 days a week, for anywhere from 3 to 4 hours of treatment at a time. This is why this 1% of the population is costing 7% of the Medicare budget. So there are some known racial and ethnic disparities throughout all stages of chronic kidney disease, including and especially end-stage renal disease. When compared to whites, Black Americans are about 3 times more likely to suffer from end-stage renal disease. And for every, three times more likely, and Native Americans are approximately 1.5 times more likely to develop end-stage renal disease in their lifetimes. For every 3 non-Hispanics who develop end-stage renal disease, at least 4 Hispanics will develop end-stage renal disease. Hispanic dialysis patients are more likely to have dialysis-related complications. And similarly, Black patients are not only more likely to have end-stage renal disease than non-Hispanic patients, non-Hispanic white patients, but they also are less likely to be listed for kidney transplant, which is the ideal treatment modality. Although non-white dialysis patients have overall lower mortality rates than white patients, and some of this may be due to the fact that white patients are usually older and have more comorbidities at the time of dialysis initiation and therefore are more likely to pass away. Data are mixed on whether or not women are diagnosed more often than men with chronic kidney disease, because the databases that exist to really look at disparities vary across countries, and so this data isn't always collected. There's no clear sex-related prevalence pattern that we can see so far. What we do know is that men are more likely to progress to end-stage renal disease and do so at a much faster rate than women if diagnosed with chronic kidney disease. And just so that we're clear, we're not talking about gender here, we're talking about sex. And sex is usually assigned at birth by healthcare providers based on the external physical anatomy, as opposed to gender. There are more people who live and fall outside that sex binary, and there really isn't any data collected at all at this point to include gender differences. In terms of age, CKD does occur more commonly in those over the age of 65. About 38% of patients who, about 38% of patients who are on dialysis are older adults. So when we're talking about this vulnerability in dialysis patients, one of the things that we're concerned about is this increased mortality. An increased mortality for a hemodialysis patient is somewhere around 17% per year. Much of this mortality is related to fluid overload that then contributes to cardiovascular morbidity and mortality. Fluid overload specifically is operationalized by interdialytic weight gains. Interdialytic weight gains are the fluid gains between the end of one dialysis session when all of the fluid has been removed and the start of the next dialysis session. It's typically the result of sodium consumption and excessive thirst that's driven by the sodium consumption and their inability to get rid of wastes. And so this kind of thirst-driven water consumption leads to sometimes an excessive amount of fluid shifts. We know that lower sodium intake is associated with less interdialytic weight gain and improved blood pressure and survival. but it's also very hard to measure sodium intake for patients at baseline. Do we do dietary recalls? Do we have patients keep diaries? And if we do, how reliable are they? How is a patient able to gauge the amount of sodium that might be in something that's processed and prepackaged versus knowing exactly what a spoonful or a teaspoonful of sodium is? One of the ways that has been recently used is something called bioimpedance spectroscopy. It's a non-invasive instrument that's used to estimate body composition. Specifically, it runs small frequencies through the body, kind of like electrocardiogram would, and then gives us an idea of where the fluid is. It can estimate, it can give you 3 estimations in under 30 seconds. And we use it often to average how fast this electrical impulse is flowing through tissues, and that gives us the idea of what the body fluid composition is. There have been a lot of studies that have demonstrated the use of the bioimpedance spectroscopy, and that it shows that it is correlated with all-cause mortality in patients with end-stage renal disease. What we don't know is whether sodium intake has an influence directly on fluid overload in end-stage renal disease. And if it does, can we measure it with a bioimpedance spectroscopy and over time? So to this end, we conducted a 3-group double-blinded parallel randomized controlled trial of 42 hemodialysis patients. The patients were randomized to one of 3 groups and admitted to an inpatient research center, formerly known as the Center for Human Phenomic Science. Patients were assessed for the effects of sodium intake on their hemodialysis symptoms, and they were either in a 1,500 milligram group or a 2,400 milligram per day sodium group. And we had a control group that was allowed to consume an unrestricted amount of sodium, I say in air quotes. The goal was to have these patients select off a menu and hopefully use the education and training they had been given in their dialysis centers to be closer to what they've been instructed to eat. All 3 sodium groups received identical trays with the same amount of caloric intake. The only difference was the sodium amount. Patients were recruited from Philadelphia, and we went to 3 different dialysis centers. And again, what we wanted to see was, is there a difference in symptoms and weight gains if we put you in a different sodium group, regardless of what your background is? And if so, was there also a difference in dialysis-specific variables like fluid gains, the interdialytic weight gain? And lastly, could we see where that fluid went? Was the total body water higher or lower if you had the higher sodium group? Was there more fluid inside your cells or outside your cells, depending on what sodium intake group you were in? And could we see that using the bioimpedance spectroscopy? And so our patients, as I said, came from 3 dialysis centers. The inclusion criteria were that they had to be undergoing maintenance hemodialysis for at least 3 months. The concern there is that as we're sort of switching around sodium groups and essentially causing fluid shifts, how that would impact people's cardiac health. What would that do to your heart? What would that do to your blood pressure? They had to be 21 years of age or older, thinking that those of us who are 21 years of age or older typically would be able to manage our own dietary choices. And they had to be able to read and write English. The exclusion criteria were if a patient could not read or write English, if they were planning to move outside of the area or change dialysis centers within the 6 months following recruitment, they couldn't be in the study. We also excluded patients who had terminal illness or a life expectancy less than 12 months because that's how long we intended to follow them for. And if they were planning to get a donor transplant during the conduct of the study. Lastly, we avoided those patients who had high heart failure classes, given again that we didn't want to make anyone more ill than they already were. Pregnant patients were excluded, and those who had defibrillators or pacemakers. Because the bioimpedance uses those frequencies similar to an electrocardiogram, while there's no data that suggests that it's a danger to patients with defibrillators or pacemakers, as you can imagine, I was not willing to take that chance to see if we were going to have some sort of adverse event. And lastly, cognitive impairment. So if patients had any sort of cognitive impairment or were unable to provide informed consent, they were also not considered for the study. So we looked at a couple of things. I am very interested in symptoms and how dietary sodium intake results in symptom changes based upon the fluid that patients consume. And so we looked at the kidney disease quality of life scale, which is typically used as a baseline instrument. It's supposed to be administered every 3 months, and it gives a long-term assessment for that 3-month period of how well the patient is doing on 5 different subscales. So it looks at physical, mental, burden of kidney disease, the symptoms or problems related to their kidney disease, and how their kidney disease is affecting their life. Again, this is usually just a baseline instrument. It's only ever given typically every 3 months. It's really long. And so in order for us to get an idea of how patients were doing during that 5-day hospital admission and that 5 days of dietary restriction, whichever group they might be in, we did something called the POS, or the palliative care outcome scale, the renal edition. And it essentially looks at the same symptoms that the kidney disease quality of life survey does, but it looks at the symptoms in real time. So did you have these symptoms today, or did you have these symptoms for the last 3 days? It's a short-term survey to evaluate the severity of symptoms in advanced kidney disease. And so if you had higher scores, then it reflected higher symptom burden. We also looked at body composition, and again, this was through the bioimpedance spectroscopy. Total body water, extracellular fluid, intracellular fluid, and interdialytic weight gains were measured at the dialysis center. So the interdialytic weight gains are part of the typical function and run of the dialysis process. The patients come into the dialysis center, they check in, they step on a scale, we get an ID, we get their weight, their starting weight, and then after dialysis, we get their ending weight. The ending weight is subtracted from the starting weight, and whatever that kilogram number is after is what their interdialytic weight gain is. So the goal would be that patients have interdialytic weight gains of less than 2.2 kilos between any given dialysis session. Each participant was given an allotted amount of food on a tray for 3 meals a day, plus 2 snacks. They all look the same, as I said before. There was no true fluid restriction other than what patients were already told to do by their providers, and we were able to then monitor their free fluid intake in addition to what was coming in on their meals. We assessed their vitals at least twice a day, the bioimpedance spectroscopy twice a day, and the symptom surveys as well. So our data analysis was conducted with chi-square and one-way ANOVA to look at descriptive statistics to see what our sample looked like. And then we did regression analyses for the total body water, or the body composition, I should say, and R-square change tests, which essentially means we took some time to see if we could predict what the outcomes were going to be based upon which sodium group our participants were in. So hopefully this table is coming across fairly clearly for you all. What you can see is that our sample was overwhelmingly African American. We had 85% of our sample identify as African American, and 45% of our sample identified high blood pressure or hypertension as the cause of their end-stage renal disease. We were about balanced in terms of sex. It was 52.5% male And we had a fairly young group. The age was 56, plus or minus 11 years of age. We did the result of the regression analysis, and the regression model showed that there was no statistically significant difference among sodium intake groups over the course of the study in terms of body composition. So total body water, extracellular fluid, intracellular fluid. It didn't matter which group the participants were in, they still had the same, there wasn't a statistically significant difference in the amount of fluid that they gained between dialysis sessions. Other than the etiology of their end-stage renal disease, there also weren't any predictors of what the body composition was going to look like. What we found was patients who had diabetes had significantly higher levels of intracellular and extracellular fluid when compared to those patients who were hypertensives, which seems counterintuitive because the hypertension group is the ones we're really worried about fluid shifts. But I think, which we'll talk about a little bit later, I think it was related to sugar. And if you see this, the graphic on the right, well, my right, while we couldn't see a statistically significant difference in numbers, what we could see is a trend that is likely clinically significant. So the blue line is the control group. The control group, following the analyses, probably consumed somewhere around 3,400 milligrams of sodium a day, which should make us all take a gasping breath, because that's not anywhere close to the 2,400 milligrams that they were recommended to consume, but is about where the general population is typically at. So if you look on the left at time point one, these patients were somewhere around, 1.8 kilograms of fluid. By time point 3, they were sitting at about 2.25 kilograms of fluid. On the other hand, the 1,500 milligram group, which is the green line, they went from consuming having well over 3 kilograms of fluid between dialysis sessions down to 1.5, 1.6. And the similar outcome happened for the 2,400 milligram group. So while we didn't see a statistically significant difference, there definitely appears to be some clinical significance in that group. Now, we were hoping that that might translate into improved symptoms, but that did not. Unfortunately, we also didn't see any difference in the symptom scores of participants in any of these, the 3 groups. We followed the patients for about 12 months. And at that 12-month mark, we went back to assess them and just to see how they were doing, to follow up and see if any of them had maintained the dietary restrictions given the way they felt. And we found that about 10% of the participants in our study died within 12 months from some sudden cardiac death related event. We also learned that the participants felt like being on the dietary sodium restriction, even though they didn't know what group they were in, they felt like their clothes fit better. One of the participants told me that he thought his lady friend was going to leave him because he had lost so much weight between the start of the week and the end of the week. But also that patients were willing to stay in the hospital and undergo this somewhat arduous process, and that they enjoyed having the support of the clinicians. So some of the things we learned, we've kind of already alluded to, is that there is this potentially interesting phenomenon within our subsample of diabetic patients in terms of fluid compartments. And I said earlier I was going to talk about this again, and the reason is that during the conduct of the study, we had a handful of patients who were diabetics have hypoglycemic episodes in the middle of the night. So I got phone calls at 2 or 3 o'clock in the morning because this subset of patients would have blood sugars in the 40s. And I think what was happening is, one, we had much tighter control of what they were consuming while they were in the hospital. So they couldn't bring in, candies and drinks, sweet drinks and things like that. And so their sugars were naturally lower. But we were also giving them their regularly ordered insulin or hypoglycemic medications that was resulting in having this sort of low glycemic index. But because of that, pre-admission, I think that their sugars were so high that they had this extra fluid kind of naturally binding to the sugars in their systems. Whether that's true remains to be seen, but we're hoping to look at this in the future. Some of the studies that we looked at found that poor diabetic control was also related to interdialytic weight gain, meaning they would have higher weight gains as well. So there's definitely something going on with the diabetic patients that requires a little bit more attention. I think from the analysis perspective, while we were able to look at our aims the way we had hoped, so feasibility was definitely there, we weren't able to extrapolate any of the conclusions other than those that other researchers had already demonstrated in regards to this phenomenon. There were several limitations to my study. One is that we admitted patients and they were there for a 5-day period, but it wasn't a full 5 days. So they would come in at the end or after dialysis on day 1 and then be discharged on day 5 at the start of dialysis. That meant that we probably got a full 3 days of dietary sodium restriction with 2 half days. And even still, there's no data to suggest how long it takes for that washout period to really get an idea of how well the sodium restriction might have worked. I told you that the symptoms weren't captured. The participants really didn't say they noticed a difference. And I think some of the justification for that might have been that the participants we were working with either were kind of in this gray area. And as you could see from the table, most of them went from having really high interdialytic weight gains to very low interdialytic weight gains, like lower than what the recommendation or the guideline is. And so there weren't any symptoms for them to experience. And 2, unless the experience was significant, they wouldn't remember it because of the way the questions were posed. So the palliative outcome scale, even though it asks about symptoms in the last 3 days, unless you had something significant happen, would you really know what your symptoms were like in the last 3 days? And lastly, there was a lot of risk for human error. So in that picture earlier, there were 2 gentlemen in a room together, and the 2 of them went to dialysis together. They grew up in the same neighborhood. They had known each other since they were children. They now went to dialysis together 3 days a week, sitting next to each other in the same chairs on those 3 days for the entire time period. And then they went home together. Well, they also wanted to be admitted during the study together, and they wanted to share a room, which I thought was a great idea. And there'd be all this emotional support. What it translated into was a risk for them to swap trays and for them to be consuming the meals of others. Whether or not that happened, I can't say for sure, but there was definitely that risk. We also had a patient decide that she was going to go to the gift shop and get herself a snack, so then we had to start restricting patients. We did do a pretty good job of making sure that we were transporting them to dialysis. We packed snacks for them when they were on dialysis, so there wasn't a risk there, but I had to very quickly pull back on what they were able to do in terms of walking around the hospital, which made me feel more like a warden and less like a researcher. So next steps in terms of really trying to figure out how best to take care of this very vulnerable and at-risk population. One is to look at symptom assessments in hemodialysis, what symptom clusters mean in terms of outcomes, and then trying to take this dietary sodium study up a notch and to the next level, which is where MANNA comes in. So we are at the moment conducting an NIA-funded pilot study to explore the utility of validated comprehensive symptom surveys in the dialysis center. So believe it or not, if you go to the dialysis center now, an inpatient dialysis, an in-center dialysis center, we do not measure symptoms or really assess how patients are feeling when they come in. So my primary goal is to get an idea of the associations between symptom scores and outcomes. So are these patients having, more visits to the emergency department? If they do, are they hospitalized as a result? Do they have longer lengths of stays? What does their functional status look like? And then, of course, on the back end, looking at morbidity and mortality in the long run. And the other thing that comes along with that then is, if I can assess how Mr. Johnson is doing when he's in the dialysis center, how do I make sure that that is then communicated to the healthcare providers who are caring for him, and what do they do with that data? We have also proposed a longitudinal observational study to look at symptoms and symptom burden and symptom clusters. So what that essentially means is there a symptom that's more associated with adverse outcomes? Is it a group of symptoms or a particular group of symptoms? For example, looking at this slide, is it gastrointestinal symptoms? So constipation, nausea, vomiting, diarrhea, and decreased appetite. If patients have those 5 symptoms, are they more likely to have an adverse outcome? Or is it the number of symptoms that they're experiencing, and is that more likely to result in an adverse outcome? And if so, who are those people who have the higher burden, who have the increased number of symptoms, and what their symptom clusters look like, and then how we can follow them moving forward to reduce their risk and their morbidity and mortality. It's actually being reviewed today at some point by the National Institutes of Health. So we'll see how that one goes. But lastly, and probably the one that everyone is most interested in, and how Julianne and I became acquainted, is we are hoping to take this opportunity that I take the study and the lessons learned from my dietary sodium restriction study, and see if we can do something with medically tailored meals. So I spend a lot of time with my study participants and my patients, and as you can imagine, these are patients who are often in underserved, under-resourced communities. They are typically low socioeconomic status patients. They are patients of color. They are also patients who have low health literacy. And so the question is, can we help them with this prescribed sodium restriction? Many of my patients can clearly articulate that they need to reduce their sodium intake. However, they also say that they're unable to do it for various reasons, whether that's convenience or access, or enough money to pay for it, caring for others in their home. And so the goal would be to see if we can use MANNA's meal deliveries to keep our patients that are in the neighborhood and maintain them as community dwellers, with a randomized study to one of 2 dietary sodium groups, keeping them somewhere around the 3,400 milligram group, which we know is what people consume on a regular basis, and what my dialysis patients did during that study, and the 2,000 milligram medically tailored meal that's currently provided by MANNA, and see what happens with patients in terms of their arrhythmia burden and hospitalization. Again, we had 10% of our patients pass away in about 12 months' time, secondary to sudden cardiac death. And the concern is that that is related to arrhythmia burden. And the reason that they're having these cardiac arrhythmias or these strange heart rates is because these patients have these shifts in fluid. And over time, like any other muscle, the heart gets worn out and isn't able to do what it needs to do correctly. So the goal would be to give these meals. We'll have them monitored with portable arrhythmia monitors for a given period of time, and then see what their outcomes are over the 12 months. Looking at some of the other measures that we were talking about before as well. So body water composition, looking at symptoms, looking at their vital signs, what their heart rate is doing, what their blood pressure is doing as well. So I think, oh, right on time. It's 1:42, so I'm going to open it up for questions. If you have any questions or would like me to share anything specific about the study or some of the work that we're planning to do, feel free.
Great. Thank you so much. That was so interesting. If anybody has questions, please feel free to put them in the chat at this time. So we'll get started with a couple of questions. There was one that came in that said, do you think the intervention was long enough to lead to significant findings? And if not, Maya, like, what do you think is a good interval for where you would begin to see effects and symptoms or other kinds of measures?
So this is a great question. And I will tell you in full disclosure that our timeline was really restricted by the amount of funding that we had. So no, I do not believe that that was long enough. It just didn't give us enough time to really evaluate what the outcomes were. But what we did see is that it is long enough for the washout. So we know that that 3-day period is sufficient for to see a difference in sodium intake and how that might relate to interdialytic weight gains. Our goal then is, in the future, I hope to admit patients a bit longer and see if we can truly see an outcome in that regard. So our plan for future is to admit patients for at least 7 days and 7 full days, so that they would start, say, for example, at 7 a.m. on day 1 and end at 7 p.m. on day 7, to ensure that we're getting, you know, the best outcome and the fullest bang for our buck in terms of the data we want to look at. But no, it was not long enough at all. And the unfortunate part was we really didn't have any data to base that upon. So myself and a group of nephrologists sat around and we went back and forth. We started with 3 days and just were like, that's not going to work. The 3 days wasn't enough, and knew that we couldn't afford to pay for 7 days. And the literature did show some washout period around 3 days, which is why we started there. So we added the extra 2 days to give us a little more wiggle room, but we should have done the full day 1 and day 5, I think.
Okay, thank you. Somebody was asking if your study was published, and I believe it was.
It is, and
yes.
I can share that. I can share the references if that would be helpful.
Great. We can, if you don't mind, we can add that to our website
Sure.
when we're done with the seminar. So
absolutely, I'll share them with you.
Let's see. Any other questions? Somebody wants us to share a little bit more about the medically tailored meals. Did you want the meals that were done in Maya's study and provided in the hospital, or do you want to know a little bit more about MANNA's meals? So if you could type that in. I have a question also while we're waiting. The symptom scores look really like a very interesting tool.
Yes.
So how prevalently are they used in the area of renal dialysis? And do you have any sense of what you're looking for to change on that whole list in regard to alterations in sodium intake?
Yeah, so unfortunately, I'm trying to think of the PC way to say this. So symptom scores are supposed to be measured. It is mandated that the symptom scores are measured using that kidney disease quality of life scale every 3 months. It's probably done once a year. In truth, it's probably done once a year. Now, having spent a ridiculous amount of time in the dialysis centers, I understand why. It's one provider to upwards of 48 patients at a time. There may be, 4 different areas in that unit with one nurse and one dialysis tech. It's just not, they'd have to wear roller skates to really hit every patient, which is why we're hoping we can develop this in some way so that patients can sit down at their chair, they can enter into the computer that's attached to the chair what their symptoms are, and then we can flag a physician to say, please go see Mr. Johnson. His depression score is this, his symptom score is that, and how best to make sure that that happens. I think in terms of sodium restriction, I feel like the sweet spot is somewhere around 2. It's somewhere around 2,000 milligrams. I really firmly believe that. But my concern is, how do I get people to do that at home? How easy is it to make a 2,000 milligram a day sodium diet, especially on a fixed income? So that's the next step. If we can prove that this works, then perhaps I can convince my patients that they should do it. If I can say, I can reduce your risk of sudden cardiac death by X, if I can improve your symptoms by X, maybe they'll be more likely to do it. So we're hoping to push forward and get that data so that we can really give patients something they can hold on to.
Yeah, that sounds like that would be fairly motivating, I would think. So that's really great.
It's my goal.
So I'll answer the person's question here a little bit first about MANNA meals, and then you can talk about the meals that were offered in the days in the hospital. So in terms of MANNA, we're a full medically tailored meal program, which means that we provide 21 frozen meals per week where we deliver to our clients once a week. In terms of patients with end-stage renal disease, we often serve those patients anywhere from 3 to 6 months or potentially longer if they need it. We are short term, and so we do, our clients work with our registered dietitians while they're on the program to be able to follow a lower sodium diet when they're off our program. And so we do what dietitians typically do, is assessments and work with in medical history, and work with clients to help them be able to find sources of appropriate foods, as well as to construct them together in meals after they're off the program. We have not measured that yet in terms of long-term success, but we're hoping to do that at some point through the evaluation work that we're doing with the MANNA Institute. So Maya, could you comment on the meals that were prepared for your patients while they were on the program?
So this research center had a kitchen that provided these meals. They were developed and prescribed by a dietitian. She actually went to the grocery store, read, the backs of different products, and then she made meals she thought people would enjoy. So they had everything from chili to baked chicken to tacos, and she tested them on all her elementary school children. And then that's how the meals were prescribed. That's how the menu came to be. And she made sure that we had 3 full meals. So they had warm breakfast, lunch, and dinner. Then they had 2 cold snacks. I honestly don't know how she did it. I am absolutely impressed that she was able to get us down to 1,500 milligrams of sodium a day. And then the metabolic kitchen is what they were called. The metabolic kitchen would come, they would take the trays back, and then they would deduct the amount of food that was left on the tray. So we had almost exactly what the sodium consumption was for that particular day for patients. So it was actually really great. I am very thankful to them, because I can't imagine making a 1,500 milligram of sodium per day, anything. And they were able to do it for 42 patients over a 6-month span.
Yeah.
There was a question on the back end of that. Let me see.
Thank you. I'll say one other thing, that one of the things we do know, and this may be answering the second part of this question as well. So as we look ahead to do this, one of the things that we do know in our client surveys is that the clients express that they really learn a lot just from having the meal in front of them. We'll often get comments of, I just didn't know what the distribution of food was that I should eat. I didn't know sort of how much of everything I should have, or, that I should have fruits and vegetables with all of my meals. And, it's very typical things that the public experiences as well. There's a confusion about sort of what we all need to do to eat in a healthy way. And in particular, our meals are geared to kidney disease in particular. So just having that example in front of clients does seem to help them at least gain knowledge. But of course, we'll want to measure that as we go into the future.
And I feel like the patients really felt encouraged when they noticed a difference, that their pants were looser, that they felt better anecdotally. We couldn't see it in the data, but the conversations that we were having was definitely that patients were feeling better. In hindsight, I wish I had done a little bit better measurement, but now we know for the next study, what it is we need to be looking at in terms of making sure that we can get, the black and white numbers and the statistical significance, so we can get someone to pay for this.
Absolutely. Somebody asked the sodium content of MANNA meals. It's 2 grams of sodium.
And then I see Sandra wanted to know why home care nurses are not trained in PD.
Right.
This has also got to be one of those PC answers. I don't know, but most of dialysis management in the US is now conducted by pay-for-service programs. So DaVita, Fresenius, and so their nurses are the nurses who do home PD. There's not a good answer. There's no good answer, but that is the truth of the matter, at least.
It's more of the U.S. healthcare system
issues. I would love it if all nurses, or at least, a subgroup of nurses, were able to manage PD patients, because it's such a unique niche, and there are way more patients than we know that are on PD that could use the support. I will say they do very well with PD at home, but it's not without a lot of work, for sure.
Yeah. So I'll ask one last question, unless somebody has other questions to kind of think about. You had presented at the beginning of your talk here about end-stage renal disease in the U.S. being some of the highest rates in the world. Mm-hmm. That's really shocking. And I know you've done some work in this area as well. Can you describe what some of the risk factors are that are possibly particular to the United States or different subpopulations in our country?
Yes. So the biggest, I would say now, 3 risk factors are obesity, high blood pressure, and diabetes. Overwhelmingly, it's our patients with high blood pressure and diabetes. They're the top 2. But I feel like obesity is just kind of out there causing more trouble. It's causing high blood pressure and it's causing diabetes. Yeah. We're just not calling it what it is. And so it's definitely those 3. And then the subgroups tend to be minorities that are overrepresented. And I didn't even really touch on, indigenous populations. I didn't touch on Asian populations, but overwhelmingly all minority groups, whether that's a racial or ethnic minority, have higher incidences of chronic kidney disease. Yes, it is the sad diet.
Well, that's good.
I'm gonna steal that one. The standard American diet. I like it.
That is very good.
I like it. It's true though. We don't do our bodies good at all with the things that we consume. And one of the things that we're trying to look at now is just with how close it is from a dialysis center to fast food. When I was in Pittsburgh, you walked out the front door of the dialysis center and there was a Arby's or a McDonald's or Burger King. And patients get off the machine and they're hungry and they're tired, and it's easy and it's cheap to go to McDonald's. And I can't say I blame them for doing it. It's accessible. So I think if we could figure out a way to make healthful food more accessible to those who need it most, we could get rid of some of these chronic conditions. Type 2 diabetes specifically, we could decrease the incidence of chronic kidney disease. We could decrease the incidence of hypertension too. But how do you do that if you can't afford it, or you don't have access to it, or your neighborhood doesn't have, a farmer's market?
Yeah. Thank you so much, Maya. We were so thrilled to have you with us today. For everybody on the call, we'll post some additional information on our website for some of the questions that you asked today. Thank you for joining us. And we'll be planning another seminar in a few months. So we'll keep you on the mailing list. Thank you, everyone. We appreciate.
Thank you for having me.
Maya, we appreciate your time. Thank you.
Have a good one.
You too.